My name is Dr. Sidra. I'm resident surgeon of ENT Head and Neck Department at Civil Hospital, Karachi. Today, my topic of presentation is the frequency of malignancy in contralateral thyroid lobe after completion thyroidectomy. About thyroid cancer. Next, can you move the slide next? Who is responsible for the? Hello, Dr. Rachel.
Yes, give me one moment.
Yes. Next. About thyroid cancer. Approximately 95% of all endocrine tumors are thyroid nuclear. Next. According to an international study, there was about 448,000 cases reported in 2020. That includes 2,700 cases from the Pakistan. Next. About the prevalence of thyroid cancer, the prevalence of thyroid cancer found to be 2 to 5% of all cancers in female and less than 2% of all cancers in males. Next. And the papillary thyroid cancer is found to be the most prevalent of all thyroid cancers, about 80 to 85% of all cases. Next. Then how does it present clinically? According to the ATA guidelines, the most thyroid cancers present as thyroid mass or thyroid nodule. Next. But in some instances, thyroid cancer may be diagnosed with the histopathology of the resecting of the suspected benign-looking nodules. So what to do in these conditions? Next. In these conditions, can you move back? Can you move back? Little back. In these conditions, next. The next slide. In these conditions, completion thyroidectomy is indicated by most surgeons, which is defined as the removal of the remaining thyroid tissue of either ipsilaterally or contralaterally if the histopathology of the initial thyroid surgery is proves to be malignant. Next. So the aim of this study was to estimate the frequency of malignancy in contralateral thyroid lobe after completion thyroidectomy. Next. And to predict the positive factor that can anticipate the presence of contralateral malignancy in contralateral lobe. Next. About methodology, it was a cross-sectional study conducted in ENT1 ward or Civil Hospital, Karachi from year 2020 to year 2022. The sample size was calculated by WHO sample size calculator by using the prevalence of 16%. Next. About inclusion and exclusion criteria. The inclusion criteria is divided into patient's criteria and the tumor criteria. About patient criteria, all adult patients of either gender were diagnosed case of thyroid cancer after initial thyroid surgery. Next. About tumor criteria or differentiated thyroid cancer such as papillary thyroid cancer, follicular thyroid cancer, and Hurther cell carcinoma of initial stages with no gross external thyroid extension, with no lymphovascular or locoregional metastasis. Next. About exclusion criteria, all non-consenting patients with abnormal TSH or patient with the medullary, anaplastic or lymphoma or poorly differentiated thyroid cancers or patients with advanced T stages or in any of the lymphovascular locoregional or locodistant metastasis were excluded from this study. Next. About data collection and analysis, study was conducted after the approval of IRB of DUHS. Each performer was filled personally according to each patient's records after taking informed consent. Data was collected and compared based on the age, gender, size, and pathological type with SPSS version 23. Next. About results, out of 68 patients, 26 patients were male and 42 patients were female. The mean age of presentation was 36.4, ranging between 18 to 80. Next. About the type of malignancy in the primary lobe. Out of 68 patients, 38 patients was diagnosed with papillary thyroid cancer, 26 with follicular variant of papillary thyroid cancer, had 2 patients of each follicular and Hurther cell carcinoma. Next. About the type of malignancy in contralateral lobe, out of 68 patients, 22 patients were diagnosed with the contralateral malignancies, in which the most of the patients were follicular variant or papillary thyroid cancer, followed by papillary thyroid cancer, and fourth with follicular and Hurther cell carcinoma. Next. If we compare the type of malignancy in the both primary and the contralateral lobe, the most common type of malignancy in the contralateral lobe was follicular variant of papillary thyroid cancer. Next. About the size of nodule in the primary lobe, the mean size of nodule in the primary lobe was 1.63 with the standard deviation of 0.22 centimeter. Next. About the size of nodule in the contralateral lobe, 86% was less than 10 mm and are of follicular variant or papillary thyroid cancer. Next. If we compare the size difference between the primary and the contralateral malignancy, the mean size difference between the primary and secondary tumor was 1.3 with a standard deviation of 0.23 centimeter. Next. If we focus on the relation of the multifocality to the type of malignancy, there was a significant association between the papillary thyroid cancer and the multifocality, with the mean number of foci ranging from 2 to 3. With the follicular thyroid cancer, the mean number of foci was 1 to 2. Next. The relation of multifocality of the primary lobe to the contralateral malignancy, there was significant relation. With the one focus, the incidence was 6%. With the two foci, the incidence was 30.2%. While with the 3 or more foci, the incidence was 46.2%. Next. Conclusion. The study shows that 1/3 of all patients have contralateral carcinomas, mainly of micropapillary thyroid. Multifocal papillary thyroid cancer have high risk of contralateral tumors necessitating completion thyroidectomy. Patients having follicular variant of papillary thyroid cancer, the future risk should be discussed with the patients who do not go for the completion thyroidectomy. Next. And the middle-aged females are more susceptible to contralateral malignancy. Next. See, madam, these are my references. Thank you. Thank you everyone for listening.
Thank you, Dr. Sidra. And I would also like to thank Claire for taking care of the slide share.
So I have been selected for the presentation of use of sternocleidomastoid flap in parotid surgeries. We did the study in 2021 to 22, and the study was done to see if there is a better post-operative contour of the patient post parotidectomy. So, as we know that salivary gland tumors account for almost 3% of all the head and neck tumors, among which the parotid gland tumors account for only 80% of all the salivary gland neoplasms. The surgery, as we know, it's a very challenging procedure because we have to preserve the facial nerve, and also post-op complications like facial contour is concave, and also there is increased skin necrosis and Frey syndrome, which are a big drawback in this procedure. As we know, this parotidectomy produces the cosmetic deformities. So we plan to do SCM flaps. And as we know, the sternocleidomastoid flap, it receives the blood supply from the three arteries. The superiorly, there is a occipital artery, which are branches of the external carotid artery. Then in the middle third of the SCM muscle, it is supplied by the superior thyroid artery, and the inferior one third is supplied by the transverse cervical artery. So in our studies, we did a prospective study, like 35 parotidectomy cases. We analyzed. In group A, there was no use of sternocleidomastoid flaps post surgery, and in group B, which we had a few patients comparatively, there were around 15 patients in which we used this flap. So after the proper anesthesia and using a typical modified Blair's incision, we did the parotectomy according whatever the disease is. Like for example, if it is a benign lesion or a malignant lesion, in benign lesions we used to do adequate parotectomy or superficial parotectomy. In malignant cases, accordingly we used to do it along with the neck dissection also. So in both the cases, with the modified Blair incision only, we used to elevate the flaps inferiorly up to the clavicle, and from there we can dissect and retract the SCM muscle. So after retracting, we can see all the blood supply, meaning the arteries and the branches of the SCM muscle can be seen. And after carefully dissecting out the spinal accessory nerve, we used to decide how much we have to take the flap. So after deciding how much length will be required for preserving the facial contour, we used to give an incision over the sternocleidomastoid flap and then fix it to the surrounding soft tissue, and then put the flap and suture the flap with the drain. And post-operatively, we followed that the results in the group A, which we didn't use the SCM flap. There were few of the complications. For example, there was two salivary fistula, and these were mostly in the old age patients or very thin flaps, where the SMAS flap was very thin, and one patient with Frey syndrome, and two patients with flap necrosis. Those patients were mostly those very huge defects, and usually with patients with morbidities like diabetes. And in the five patients, mostly there was a contour deformities, which we saw, especially the female patients had a very proper concern that they used to complain post-operatively, even though everything was fine, they used to complain about the contour deformities. So therefore, I can say that this sternocleidomastoid flap is a very relevant operative technique to be used in parotectomy because it forms no contour deformities. And there is also significant advantages like no Frey syndrome and no salivary fistula, because it acts an extra layer over our flap, which is afterward the skin flap, which is sutured. For example, this is one of my cases in which this is actually showing the post surgery defect. This is the this is a defect which was produced after the surgery was done, and so we elevated the SCM flap adequately. Only as much as required, we have to elevate the sternocleidomastoid muscle and then suture it to the nearby soft tissue areas. In this case, this is a benign case, or you can see a remnant of the uh, parotid gland which is remaining. So we used to suture to the surrounding tissues and then suture our final layers. In my discussion of this topic, I will say that the use of sternocleidomastoid is a very relevant operative technique which will help in the aesthetics. There are other cases in which they have found this, that the Fraze syndrome with the SCM flap was very much less. For example, 12.5% in Castor et al. Study, it was seen. And for example, in many other studies also, it helps us to know that it is a very important advantage of helping us offer a better contour of the patient, better nerve coverage in fistula present, and the prevention of the fistulas and Fraze syndrome. This is a photo, a picture which helps us in knowing the occipital artery branches superiorly. The middle third is showing the superior thyroid artery, and the inferior is showing the inferior thyroid artery, which is actually the thyrocervical artery is the main branch. So I would like to conclude my study about this presentation of mine. It's a short study in which we had a very significant amount of relevant conclusion that it is a very much important procedure to be taken during the post-parotiditis. I have done my 2-year fellowship in head and neck onco surgery, but in here I have not seen much this practice being done in the patients. So it's a very helpful method to prevent all such complications. These are my references, and I would like to thank Dr. Neeral Modi, who has been my guide in this study and who has taken up this effort to present this type of cases, such innovative techniques in otolaryngology, which will be actually benefiting the patients. Thank you very much.
Thank you so much, Dr. Shivangi, for your presentation. It was truly insightful. I'd like to thank Scientific Conferences for giving me this opportunity to present my paper. Okay, I will start. I'm going to be presenting on the effect of chest proprioceptive neuromuscular facilitation on the respiratory status of post-stroke survivors, a systematic review. As we all know, stroke is one of the leading causes of worldwide disability and an increasing burden of stroke in India, with the fifth foremost cause of disability and fourth chief cause of death. About 59% of patients die in the first 5 years, and 61% of patients die in the first 7 years. A sudden loss of neurological function caused by the interruption of blood flow to the brain is termed as stroke. It can either be an ischemic, hemorrhagic, thrombotic, or an embolic stroke. When the brain gets deficit of oxygen and nutrients through any one of the types of strokes, it can result in cell death. An ischemic stroke is when an artery gets lodged and the blood supply to that area is compromised. In an hemorrhagic stroke, we can see a rupture of an artery, which causes increase in the intracranial pressure. In an embolic stroke, it occurs when a clot is dislodged from their original site and can lead to a thrombotic stroke. A transient stroke is when the clinical features are seen for less than 24 hours. A major contributing factor is atherosclerosis. This is the deposition of plaque with the accumulation of lipids, fibrin, and complex carbohydrates. According to the American Heart Association, the warning signs can present as sudden weakness of one side of the body, facial drooping, and loss of consciousness. Ischemic cascade occurs when there is an interruption of blood flow. The neurons quickly start to die in the ischemic core area, while the surrounding penumbra can survive a little longer. According to the type of stroke, necessary management is decided. But when a person is in the hospital for an extended period of time, it can harbor a lot of respiratory complications. With this, the respiratory muscle weakness can make it difficult to achieve a normal chest expansion and normal expulsion of secretions. Intensive care chest physiotherapy, such as percussion, vibration, shaking, can be given. In addition to this, we can give the patient chest PNF to aid in recovery. That is when an external proprioceptive and tactile stimulus is used to produce a reflexive movement response to assist respiration. This is the basic principle behind neurophysiological facilitation, which causes involuntary cough response, directly reducing the amount of suctioning required. Techniques such as intercostal stretch, anterior stretch basal lift, perioral pressure, co-contraction of the abdomen, all these techniques help in increasing the epigastric excursion. This is in a CT of one of my patients. So the need in this study is in patients who have encountered stroke, one of the main side effects seen is hemiplegia, which is seen as one-sided weakness. This includes the chest muscles, and this leads to the patient being ventilated. So even if the patient is conscious, but the chest expansion is not ensuring maximum ventilation perfusion, the patient has to be ventilated. In such cases, in addition to conventional rehabilitation, chest PNF has shown to significantly improve the chest expansion and perfusion. This systematic review encloses 9 articles which have administered various chest PNF techniques and have compared their benefits. The aim here is to understand the effect of chest PNF in stroke patients. The objectives are to understand which PNF technique can give us the best outcome and to understand which kind of response and which technique can elicit what response in the patient. This is a review of one of my articles which I used. So in this diagram, I have explained how I came to conclude the 9 articles. In my search engines, in various search engines that I use, such as Google Scholar, PubMed, I found various articles that were related to my topic. Once I screened, they were about 1,600. And after I scanned them through eligibility and excluded articles which were in the wrong design population and wrong intervention used, I came to a conclusion and I had 9 articles, which I will be explaining further. Here I've attached a table which I will explain it further. So the first article is Zadov et al. That concluded that anterior stretch basal lift showed significant results than intercostal stretch on improving respiratory rate and chest expansion. So they included 40 participants and divided them into 2 groups. Here, group A was given conventional therapy with an additional of intercostal stretch chest PNF technique, and group B was given conventional therapy with anterior stretch basal lift chest PNF technique. The outcome measures that they used were incentive spirometry, respiratory rate, and chest PNF, chest expansion, sorry. Waludwala et al., they used 34 subjects according to their inclusion and exclusion criteria. Group A was given a conventional treatment such as mat exercises, stretching, and strengthening. And Group B was given all the exercises of Group A in addition to the PNF techniques. They checked the FVC, FEV1, FEV1 by FVC ratio by PFT, and these were taken as the outcome measures. These were done on the first day of the treatment and the last date. And results revealed that Group B showed improved respiratory function as it was administered with chest PNF techniques. Nair et al. Conducted a comparative study in which they included 34 participants and they were allocated into 2 groups. The control group received conventional neurological rehabilitation, while the experimental group received a chest expansion resistance exercise with conventional treatment. The outcome measures were chest expansion, trunk impairment scale, respiratory muscle strength, mini Bestes test scale. The pre and post assessment were taken on the first and the last day of the treatment. The treatment course being 4 weeks, 16 sessions. Based on the results calculated, the experimental group that was given chest expansion resistance exercises showed significant improvement in respiratory function, balance, trunk control, and in patients with chronic stroke. D'Souza et al. Conducted a randomized control trial where 40 patients who were assembled into 4 groups to check the effect of trunk and respiratory patterns associated with PNF techniques using oxygen consumption, respiratory muscle strength, quality of life, thoracic volume as the outcome measures. So they were given a chest respiratory training with lower limb and respiratory, including the next group was given chest respiration training with lower limb plus PNF. Third one included upper limb plus PNF, and the fourth one included upper limb plus respiration. The treatment protocol consisted of respiratory training and 30 minutes of CRT cycle ergometer, which were performed over a span of 20 days, 3 times per week. The result concluded after performing this study was that the association of PNF in cardiorespiratory training was an effective and accessible alternative to increase cardiorespiratory function in post-stroke patients. Slupa et al. They took 60 patients and divided them into 2 groups. Group A was given PNF treatment for respiratory muscles, and Group B was given positioning as a reference group. Pre and post assessment was done using the Barthel Index Scale EMG recording of the respiratory muscles as the outcome measures. This was to conclude that PNF treatment helped to normalize the breathing pattern in stroke patients and to reduce the chance of hypoxia. Tzolka et al. In their study used respiratory parameters such as spirometry, FVC, FEV1, FEV1 by FVC ratio, PFT as their outcome measure. 60 patients were used, where Group A was given PNF treatment for respiratory stimulation, and Group B was treated without PNF and was given positioning. The study concluded that a single treatment of respiratory PNF causes an increase in airflow and increase in the FEV1 to FVC ratio. Song et al. In their study used 40 patients, divided them into 2 groups. Here, Group A was given chest resistance exercise, diaphragm resistance exercise by the means of PNF. Group B was given chest expansion exercise, which included exercises such as respiratory exercises and chest expansion in various positions. Outcome measures were forced volume vital capacity FVC, FEV1, trunk impairment scale. The treatment lasted for 8 weeks, 30 minutes per session, 5 times a week. Results revealed that both groups showed an improvement in increasing respiratory function and trunk control, but Group A showed significantly more improvement. Kim et al. Conducted a randomized control trial in which 40 patients with chronic stroke were chosen. Group A was given it was the experimental group in which chest expansion resistance exercises were given for 20 minutes. Group B, the control group, was given a passive range of motion exercises. Chest expansion, vital capacity, forced vital capacity, and forced expiratory volume in 1 second. 6-minute walk test, 10-meter walk test was done as the outcome measures. It was concluded that the chest expansion resistance exercise proved to have a better outcome on the respiratory function in chronic stroke patients. Gupta et al. Used 30 ICU patients who fulfilled their eligibility criteria. Group A was given intercostal stretch, while Group B was given anterior basal stretch. Outcome measures used here were heart rate, oxygen saturation, respiratory rate. Pre and post outcome measures were done on the first and the third day respectively, and it was revealed that the intercostal stretch was more effective in reducing heart rate and respiratory rate and improving oxygen saturation. So in my discussion, Jadhav et al. Concluded in their study that the conventional physiotherapy along with respiratory PNF has a positive effect on chest expansion, respiratory rate, and spirometry. Due to the applied tactile and proprioceptive stimuli, this helps increase the intrathoracic lung volume and lead to a higher percentage of flow rate. Valudwala used and came to the conclusion that the chest expansion resistance exercises were more effective in improving the trunk function, balance, and mainly respiratory functions in chronic stroke patients, as it is based on the principle of PNF, in which a stretch reflex resists the change of muscle length, thereby facilitating a contraction in the stretched muscle via its muscle spindle. Nair et al. Came to a conclusion that respiratory parameters of PFT showed a positive effect due to respiratory PNF, as the proprioceptors and mechanoreceptors are activated, which showed the effect on the muscle spindle and tendon that are sensitive to the forces of respiration, which in turn caused an increased coordination in the respiratory muscles. D'Souza et al. Concluded in their study, which revealed that cardiorespiratory functions can be improved with a combination of cardiorespiratory training and chest PNF, as it causes alternating isotonic contractions to occur by the principle of stabilization reversal. Slupa et al. Came to the conclusion that PNF treatment can reduce the overactivity of accessory respiratory muscles and can normalize breathing patterns, as PNF to the primary muscle of respiration can reduce the bioelectric activity of the accessory muscles and improve lung oxygenation and ventilation. Tawolska et al. Concluded in their study that the respiratory parameters can be increased by a single intervention of respiratory stimulation through PNF, as it increases muscle expansion in the peretic side, which in turn increases the respiratory parameters. Song et al. Concluded that chest resistance exercises is more effective in improving the respiratory functions of the trunk control, and this technique enhances the respiratory muscle strength and endurance, causing it to have a direct effect on the respiratory status of the patient. Kim et al. Came to a conclusion that chest expansion resistance exercises plays an important role in alleviating the respiratory functions in stroke rehabilitation. These techniques facilitate the respiration, which increases the airflow that is translated due to the increased chest expansion. And lastly, Gupta et al. Revealed in their study that using intercostal stretch techniques are more effective in reducing respiratory and heart rate and improving the oxygen saturation than anterior basal lift, as intercostal stretch has an effect on the alpha motor neuron, which directly has an effect on the muscle fiber to initiate contraction. However, the study has limitations regarding the specificity of the chest PNF technique. The study focuses on overall techniques and is not pertaining to a single specific technique and its impact on the outcome. As a summary, a total of 9 articles were included. The study design for all the reviewed articles were consistent, which is a randomized control trial. 3 articles that were included had a study duration for 1 day. The remaining studies had a duration of a minimum of 3 weeks. 1 article used EMG as their outcome measures, and all the studies had a component of chest PNF in their intervention. In conclusion, the above articles mentioned were examined thoroughly and gave a summary of the effect of chest PNF on the respiratory status of a post-stroke survivor. The studies that were evaluated showed significant results in increasing the tidal volume, oxygen saturation levels, while maintaining the respiratory rate in post-stroke patients due to the chest PNF technique. Air exchange was increased by various techniques such as intercostal stretch, anterior basal lift, perioral pressure, intra-abdominal pressure, making it useful in improving the respiratory status of post-stroke patients. These techniques can be used to facilitate the diaphragm muscle and inhibit the use of accessory ones for respiration, which will facilitate the correct pattern of breathing. Intra-abdominal pressure can be used to facilitate a cough reflex and aid in the expulsion of secretions. These are my references. I would like to thank everyone once again for listening, and I would like to thank my faculty here at Krishna Vishwavidyapeeth and my co-author and my guide, Dr. Suraj Kanse, for helping me to make an article and to publish it. Thank you everyone for listening.
Thank you, Dr. Rachel. It was an excellent presentation. Are there any queries from audience side?
The chronic disease affecting the mucous membrane, the nasal cavity, and paramucous fascia. The prevalence of chronic rhinosinusitis with nasal polyposis is around 4%. The polypectomy with endoscopic sinus surgery has become one of the most common indications for chronic rhinosinusitis associated with nasal polyposis in patients who have failed medical therapy. So the cause of formation of nasal polyps is clearly not well known. The possible etiologies Suggested in few of the textbooks and articles would be aspirin intolerance, infection, allergy, fungal rhinosinusitis, cystic fibrosis, primary ciliary dyskinesia, Hair syndrome, etc. So, coming to the site of origin of nasal polyps, they originate in narrow spaces of anterior epineural, where there is point of contact between the two mucous membranes. So, the polyps are treated basically to start with either the steroid sprays or systemic steroids based on the severity. So, surgery is implicated in the cases if the medical management fails. So, then the polypectomy with functional endoscopic sinus surgery would play a part. So, the basic principle behind functional endoscopic sinus surgery would be to remove the polyps, to facilitate sinus ventilation, to absorb the topical medications used in the form of sprays. So, the conventional instruments we use tend to switch the mucosa from the underlying deeper tissues or bone, causing excessive bleeding and complications, which ultimately reduce the visibility during the surgical procedure. So, to overcome these technical drawbacks, development of specialized instruments like microdifferenters has facilitated endoscopic management of sinus surgery by precise cutting of mucosa, lesser bleeding, better visibility, and clearer surgical field. So, because of all these advantages provided by the microdifferenter, there is less post-operative complications. So, we conducted a study to study the surgical and technical, intraoperative and post-operative results of microdifferenter-assisted polypectomy with endoscopic sinus surgery. So, this is a prospective interventional study which was done at Bachwechura Teaching and General Hospital attached to Madhavapura Medical College Hospital. The study duration was between 2019 and 2020. We included 30 patients who satisfied inclusion and exclusion criteria after taking institutional ethical committee clear. And coming to the methodology, we included a meticulous history taking. Visual analog scoring was done for symptomatology of the patient. Detailed ENT examination was done, followed by a diagnostic nasal endoscopy to assess the grade of polyps, and computerized tomography scan of the paranasal sinuses was done, and limb-naked CT scoring was done to assess the involvement of paranasal sinuses. So, the patients who had a score in CT of more than 8 were considered for surgical procedure. So, we included all the patients who were clinically diagnosed with bilateral ethmoidal polyposis and who were willing to participate in the study and gave consent for the same. We excluded the patients with comorbidities and those patients who had recurrent polyposis, those had unilateral nasal disease or nasal pathology, those patients who were not willing to participate in the study, or those who did not give consent for the study. So, we intraoperatively assessed the type of anesthesia, duration of surgery, the amount of blood loss, surgical exposure of the sinuses, clearance of disease, bleeding, and difficulty removing the polyps. All this data was collected, tabulated, and statistically analyzed. So, one patient was treated for post-operatively for around 3 to 5 days in the hospital center. They were discharged and asked to follow up on 7th day post-op, 1st month, 3rd month, and 6th month. During these follow-up periods, we assessed the visual analog score for symptomatology, and also we did follow-up diagnostic nasal endoscopy to assess the status of nasal mucus and paranasal sinuses. So, the results which we drew out of the collected data are here. So, out of 30 patients, we had 15 male patients and 14 female, and the age ranged between 21 to 63 years. So, we had patients from 31 to 40 years contributing to around 14 patients, and 21 to 30 and 41 to 50 patients, we had 6. More than 50 years of age, we had 4 patients. So, the most common presentation of these patients was nasal obstruction, followed by hypoxia or anosmia. Following that was a nasal discharge, headache or facial pain, change in voice, snoring, and post-nasal drip. So, when we did diagnostic nasal endoscopy scoring, 60% of the patients had score of 3 and 40% patients had score of 2. So if the polyps were occupying only the middle meatus region, it was graded or scored as 1. If they're beyond the middle meatus, grade 2. If they're just filling the nasal cavity, was scored 3. And if they're coming out of the nasal cavity, we scored them as 4. In low mature CT patients, the minimum score we had was 8 and the maximum score was more than 8. So whoever had score beyond that were considered for endoscopic sinus surgery. So under low mature CT score, the sinus classification was considered to get anti-rhythmoid, post-rhythmoid, maxillary sinus, frontal and sphenoid were observed. And if there was no opacification, it was scored as 0. If there was partial opacification, score 1. And if there was complete opacification, score 2. And if there is osteometal block, it was score 2. If the osteometal complex was clear, it was score 0. So the anesthesia part, almost 18 out of 30 patients underwent surgery under general anesthesia, while the rest of the patients underwent surgery under sedation with local anesthesia. So the average time taken for surgery was around 47 minutes, with average total blood loss during surgery being 130 minutes. So 20 patients had grade 2 and 10 patients had grade 3 of bleeding according to Gujarat endoscopic bleeding score for endoscopic surgery. The disease clearance was complete in all the patients and the exposure of sinus and nasal cavity was quite good. This is the table showing visual analog for post-operatively. So the parameters we considered for follow-up visual analog score was nasal obstruction, nasal discharge, hypotony, anosmia, headache or facial pain, and overall discomfort. So the patient follow-up on 7th day, 16 patients had nasal obstruction, which subsequently became 4 patients at 6 months post-op. So the patient post-operatively on the 7th day had no nasal discharge, while 2 patients complained of nasal discharge by the end of 6 months. So only 2 patients also complained of hypotony or anosmia, with no patients complaining of headache or facial pain, and overall discomfort was comparatively better at 6 months post-op. This table shows diagnostic nasal endoscopy post-operative. So the parameters we consider for DNE was thrusting, thick mucous discharge, whether it is scarring or panic formation, or any other findings which we included, the polypoidal changes or polyps. This in turn was recurrence of polyps. So thrusting part, almost all the patients had minimal to moderate amount of thrust formation immediately 7th day post-op, with use of nasal douching. By the end of 6 months post-op, almost all patients were clear of nasal thrusting. So the thick mucous discharge was present only in 2 patients by the end of 6 months post-op, with no patients having any scarring or panic, and the polypoidal changes were observed in 4 patients. So this is the endoscopic picture of left nasal cavity showing healthy nasal mucosa at 6 months follow-up with use of microdebrider assisted polypectomy. Coming to the discussion part, polyps are seen in almost all age groups with average range of onset 8 seconds to 6 decades. So in our study, the polyps were seen in age groups between 15 and 63, with the mean age of presentation being 39 years. And there were more number of cases seen in the age group between 31 to 40, which was comparable to the study done by Vikas Sakareta, where the age distribution of patients ranged from 50 years to 60 years, with mean age being 37. So this was because of increased exposure to the environmental allergens. So the polyps are seen in both sexes equally, with slight predominance in males. So in our study, male to female ratio was 16:14, and this was because of increased mobility and environmental exposure in males. So this finding was similar to a study conducted by Kanishka Varman et al. 14 out of 25 patients in that study, and 16 were males and 9 were female, with male to female ratio being 1:7. So another study by Shivan et al., they also observed that men were affected more compared to females. So the varied presentation of nasal polyps is they can also be associated comorbidities like acute rhinosinusitis, chronic rhinosinusitis, allergic rhinitis, gastroesophageal reflux disease, etc. So in that study, nasal obstruction was present in almost all 30 patients with hypotony and anosmia seen in only 26 patients, nasal discharge in 24 patients. So in a cohort study on 126 patients done by Banerjee et al., they found that 15 had nasal obstruction and hypotony and anosmia were more significantly associated with nasal polyps. So in that study, 60% had score of 3 and 40% had score of 2 on DNA. This, in a study done by 60 patients by Mohan Karthikeya, they found that grade 1 polyps were seen in few patients, that 33 had grade 2 and 14 had grade 3 polyps. So Lund-Mackay CT staging, the minimum score B was 8 and the maximum was 12. So 30 patients and 24 patients had complete opacification of anterior and posterior ethmoids, while 16 patients had complete opacification of maxillary sinus. 12 patients, that is 40%, had complete frontal sinus opacification, while 12 patients showed complete opacification of sinus sinus. So the time duration for endoscopic sinus surgery with polypectomy in our study was 47 minutes, plus or minus 1.16 minutes. So in a study conducted by Kanishka Varman et al., the mean duration of surgery in their study was 51 minutes. So the lesser duration of surgery in microdeprive-assisted endoscopic sinus surgery with the polypectomy method was due to cutting and suction mechanism in the microdeprive, which reduces the change of instruments frequently while operating and also provides dry surgical space which speeds up surgery. So the amount of blood loss in our study was 113 plus or minus 17.38 ml. In a study done by Singh et al., blood loss in the microdeprive-assisted polypectomy was about 181 ml. So the less blood loss could be attributed to the use of hypotensive anesthesia, where the mean arterial pressure was maintained less than 60 mmHg in a normotensive patient and little higher in hypertensive patients. Comparatively, lesser blood loss in microdepriver method was attributed to precise removal of polyps with preservation of adjacent nasal places. So the intraoperative visibility of surgical tube during the surgical procedure was assessed in our study by Bujaj reading. In 20 patients, the surgeons operated with grade 2 Bujaj's bleeding score, while in 10 patients they operated in grade 3. In a study conducted by Shama Bellet et al., with the use of microdepriver, most patients had bleeding of grade 2. In our study, the disease clearance was complete except for difficulty in reaching the sphenoectomoidal region. We also found in our study out of 30 patients, 26 patients had histopathological report showing inflammatory changes, while 2 showed allergic physiology. So the conclusion of our study was microdepriver provides surgical and technical advantages in terms of lesser duration of surgery, precise removal of polyps, preserving the adjacent nasal mucosa, less bleeding during surgery, better surgical exposure due to dry surgical fluid, and hence better clearance of tissues. So this technique helps in better healing and lesser postoperative complications like scarring or tourniquet, and including recurrence of nasal polyps. So we found surgeons were more comfortable in microdepriver, though different surgeons operated on different patients. But the outcome of surgery depends on the expertise of operation surgeon. Better working in clinical improvement and polyp recurrence with microdeprive-assisted polypectomy was seen in that study. Though there is surgical convenience with microdepriver, initial investment for the machine would be better per surgical cost and the blade cost, including additional costs for procuring blades for each surgery, a few of the disadvantages we noted down in our study. So the references we can quoted in one study. Thank you. I have one more paper. So this is right. Dizziness is a non-specific term referred to a sort of ill feeling. It can include visualized spinning, bouncing, rocking movements of environment, consciousness internal movement, unsteadiness, disorientation or confusion, lightheadedness, near fainting, or even anxiety. So it is one of the most common disorders affecting nearly 20 to 30% of worldwide population. So this causes social and economic impact affecting quality of life in terms of functional, emotional, and physical aspects. So they are even associated commonly with depression and anxiety. So vestibular disorders disturb the quality of life because of the fear to the patient of falling, which leads to limited participation at work, avoidance of leisure, and travel. The aim of vestibular rehabilitation exercises is to control symptoms, decrease the functional disability, and reduce the quality of life. So the importance of vestibular exercises is less understood by the practitioner. So if the practitioner keeps giving anti-vertigo medication, it helping the person in central compensation. So the purpose of rehabilitation is to facilitate the ability of the central nervous system to compensate for vestibular system lesions. The significance of starting vestibular exercises early in a patient with vestibular disorders has a greater impact on the recovery as well as quality of life. So the vestibular rehabilitation gives complete recovery in about 30%, while it gives variable recovery in about 85% of patients with vertigo. Of various rehabilitation exercises we know, the most commonly advised are Cochrane 50, Herdman, Italian Association of Neurology, etc. So routinely we give advise patients to follow Cochrane 50 exercise. So the material and methods include the aims of the study there to study the effect of early vestibular rehabilitation in case of vertigo on quality of life, and also to know the importance of vestibular rehabilitation in vestibular disorders. So this was a prospective study conducted in Department of ENT, the Future Teaching and General Hospital of Otorhinolaryngology Medical College, Calcutta. So we did study over a period of 1 year on 30 patients after taking institutional ethical committee clearance. So the duration of treatment was the vestibular rehabilitation exercises were advised twice daily basis to the patient for 12 weeks. So the basic investigations which we included were audiovestibular assessment, and the patient was called for follow-up by the end of second week, first month, second month, and third month. So during the subsequent visit, we gave the patient questionnaire which included visual vertigo analog scale and dizziness handicap index score. So this is the table showing the visual vertigo analog scale, which includes per market. So these parameters were scored from 0 to 10. So based on the difficulty the patient is facing, so we can give a score of 0 minimum, but score of 10 which is maximum. So likewise, we included 9 parameters and the total score corresponded to 90. In few reference articles, they included a parameter of 10 where the score was scored till 100. So the minimum score is 0 while the maximum score is 100. Likewise, we also gave a questionnaire called as dizziness handicap inventory score, where it was classified as functional, emotional, and physical. So the functional part included 9 points, emotional part included 9 points, while the physical part included 7. So a total parameter of 25 was included, where the score from 0 to 4 was given, where for a point like restriction of travel, if the patient is comfortable, he can give a score of 0. If he has difficulty while traveling, that is dizziness while traveling, he can give a score of 2. Every time he travels and he has severe vertigo or dizziness, the patient can score it as 4. So likewise, the minimum score was 0 and the maximum score was 100. So we included patients of all ages of both sex to diagnosed with peripheral vestibular disorders were included in the study, and those patients who were willing to participate in the study and gave consent were included. The patients who had severe visual impairment had orthopedic problems restricting them to perform vestibular rehabilitation exercises were excluded from the study. And the patients who suffered CNS injuries causing added motor or sensory loss were also excluded. And those who did not wish to participate in the study and did not give consent to participate and who failed to follow up were excluded from the study. So we categorize patients into different age groups, out of which the patients belonging to age group 31 to 40 were 8, 51 to 60 were 10. So these were the two major age groups involved with complaints of dizziness or vertigo. Following this, the most common age group which presented to us with dizziness was 21 to 30 years. So out of 30 patients, we found that there was like female preponderance in this study, contributing to around 22 patients being female and 8 patients being male. And we also noticed that majority of our patient groups were housewives. That is 12 patients out of 30 were housewives, followed by teachers and students who contributed to about 20%. That is 6 patients of each category of this hospital. So the chief complaints with our patients presented were almost all 30 patients complained of dizziness. 2 patients had complaints of vomiting, 2 had ringing sensation in the ear, and 2 had swaying while walking. So this is the chart showing the visual vertigo analog score. So the meaning of each score was taken before starting rehabilitation exercises. After starting rehabilitation exercises, we took visual vertigo analog score at a period of 2 weeks, 1 month, 2 months, and 3. So here in this table, we can see that the mean visual vertigo analog score before starting rehabilitation exercises was about 29.9, which subsequently reduced to about 3.73 by the end of 3 months of doing vestibular exercises. So this is the chart showing dizziness handicap inventory score to assess for the quality of life. So the mean of dizziness handicap inventory score before starting vestibular exercises was around 29.86, which subsequently on exposure to vestibular exercises, the mean score decreased to around 6.6 by the end of 3rd. So the second table shows pre-rehabilitation score of visual vertigo analog and pre-rehabilitation and post-rehabilitation of dizziness handicap immunity. So we can clearly notice that there is significant decrease in the score of visual vertigo. This itself explains the importance of vestibular rehabilitation exercise. So coming to the discussion panel. So vestibular rehabilitation helps reduce vestibular symptoms in vestibular disorders by central compensation mechanisms by means of neuroplasticity. So these exercises need to be started as early as possible around the time when the vestibular nuclei undergo reorganization. So only then complete compensation can be expected. Otherwise, there will always be a residual giddiness in such cases. So 51 to 60 years was the most common age group involved than the real method. So this could be because of age-related balance disorder, which affects both peripheral as well as central nervous system. 73.3% females were affected in our study, which is comparable to the study done by Master et al. In their study, they had 82% of females affected with the disease compared to males. So this was attributed to the medical conditions suffered by females, including hormonal changes. In our study, majority of the patients were housewives, which contributed to around 40%, followed by teacher and student contributing to around 20%, which was similar to the study done by Otorhinolaryngology. The visual vertigo analog score significantly improved on starting vestibular exercise. So in our study, the mean score pre-rehabilitation was 29.93%, and the post-rehabilitation was 6.93. While the dizziness handicap was similar after rehabilitation. So in our study, We got business handicap inventory score, mean being 29.86, and by the end of 4 months, it was 6.66. So these two parameters were comparable with the study done by pre-method. So this showed that there is significant improvement in quality of life after vestibular rehabilitation. So to conclude, the study showed the significance of starting vestibular rehabilitation early in case of vestibular disorder and how it improves quality of life. So the vestibular rehabilitation is simple, feasible, easy to do, cost-effective, safe, short-term therapeutic modality for improving quality of life in patients with vestibular disorder. So these are the references which I quoted in my study.
Thank you so much, Dr. Prerna, for both of your presentations. It was truly insightful. If there are any
and it was later extended to my MHPE fellowship. So this work has been done for 2 major fellowships in medical education, and I'm extremely grateful to the organizers for giving me this opportunity. These are the certificates. This is the Institutional Ethics Committee approval, and these are the plagiarism certificate. And the study has been published in the JIMA index journal, which is indexed in Scopus, and the plagiarism report was less than 9%. The role of multiple assessment in medical education. Assessment plays a critical role in shaping and learning experiences and ensuring competency in medical education. Reliance on a single mode of evaluation is increasingly recognized as insufficient to capture the complex skill required in clinical practice. Multiple assessment methods, including direct observation, simulations, checklists, multiple score feedback, and self-assessment, offer a more comprehensive and valid picture of the learner's abilities. It improves reliability, validity, and fairness of judgment about trainees' performance. With reference to the present study, the National Medical Commission implemented competency-based medical education in 2019, and to support hands-on skill development in categories like show, solve, and perform, NMC had mandated establishment of skill laboratories in all medical colleges, those who do not have till now. The NMC recommends development of structured skill teaching module that includes clear objectives, teaching sessions, supervised training, and formative assessment using OSCE pattern. To ensure effective learning and certification, there is a need for validated modules incorporating systematic assessment in continuous feedback. Need of the study. Skill validation. There is a critical need of a validated module to ensure the skill is taught, practiced, and assessed systematically, aligning with the NMC guidelines. Note, module recommended by the NMC has limitation of a single summative assessment based on OSCE, and it is a feedback-driven learning incorporating multiple system assessment allows for continuous constructive feedback, which enhances the skill acquisition and longitudinal retention. Before I start, I would like to mention that the multiple assessment that were introduced in the present study did not hamper the basic structure of NMC, and all the multiple assessments that were used were primarily in form of formative assessment. Limitation of single assessment, we see lack of comprehensive evaluation, poor reflection of long-term competence, text anxiety and situational factors, low reliability, encourage rote learning, does not assess professionalism or communication, and others. And advantages of the multiple assessment include enhance the skill retention and mastery, promote reflective learning through feedback, reduces assessment anxiety, improves consistency and reliability, improves retention of skill, and supports competency-based progression. Type of the study, it is an educational interventional study, especially a prospective, quasi-experimental or pre-post study. The knowledge gap analysis we see in the studies that have been done with multiple assessment on skill module, done by David J. Nicole states the gap was identified as how learners synthesize conflicting or varied feedback, the cognitive and the effective responses to diverse evaluation, and development of multiple assessment strategies help in feedback. The study by Blackfeet shows how varied assessment types interact to build comprehensive understanding, how personalized and adaptive assessment strategies impact long-term retention and transfer of knowledge. And the study done by Harlan et al. Shows that demonstrate how formative and summative assessment can be strategically aligned in the skill lab to evaluate the impact of such integration on learning outcomes, skill mastery, and student confidence. Explore learner and instructor perception of the combined approach. Nature of the knowledge gap identified. Key aspects of the knowledge gap were limited research on how formative assessment integrated at multiple stages improved competence and reduced practice attempts. Scarce literature on combining MCQ-based evaluation with DOPS and direct observation of procedural skills and their comparative impact on long-term retention and particular performance. Lack of guidance or framework for the optimal sequencing of teaching methods and assessments in clinical skill modules. Thus, the study highlights the need for further investigate and formalize evidence-based multi-assessment strategies that better prepare students for practical real-world medical challenges. The question was, can an integration of multiple assessment in the skill training module increase proficiency and retention among undergraduate students? And the aim of the study was to introduce multiple assessments in the skill module for teaching skill. Since I'm an ENT surgeon, so I chose the skill anterior nasal packing in the skill lab. The objectives were development of a module of anterior nasal packing, which includes of developing a checklist, the theoretical part, the video demonstration, and the certification. Assessment of the learner after didactic sessions and video sessions were carried out on anterior nasal packing skill for undergraduates. Assessment of the learner after practice session on anterior nasal packing skills for undergraduate, and study of feedback of faculty learner after certification. The null hypothesis, the X0, the introduction of multiple assessments in the skill training module does not significantly improve the proficiency, whereas the alternate hypothesis, it does change the improves the proficiency of third-year MBBS students. The sample size was calculated by using the standard formula, and we had created two groups. We will elaborate in the methodology section, and each group had 25 students. The material and method, the module structure has been the basics module structure has been taken from the competency-based undergraduate curriculum for the Indian medical graduate. Module 5 skill training module, that is page number 18. Multiple assessment added to the basic structure in the form of just formative assessment, and summative assessment was not disturbed. This is the NMC module, structure of the NMC module, like the defined objective, derived sessions, plan assessment, and create resources. In the derived assessment, preparatory sessions, theoretical, practical, and video demonstration, followed by hands-on sessions, followed by final summative assessment. In this, there is no provision of formative assessment during the preparatory and skill acquisition section, which I had introduced. The methodology, this is the methodology that I adopted. Like, I divided the students into two groups with n equal to 25. Group A was the NMC module, and Group A was the module of the present study. And the difference in the evaluation was making the checklist for the module. It was not validated, and it was validated by the faculty members in Group B. Sorry. And the pre-test briefing of the students with the checklist was carried out in both the groups, whereas PPT presentation about the theoretical component of the module, there was no assessment in Group A, whereas MCQ-based assessment in Group B. Demonstration of the video component of the module, no assessment in Group A, whereas MCQ-based assessment in Group B. And practical training sessions of the students on the model for anterior nasal packing, no assessment after the practice session, whereas formative assessment was done by using the DOPS method. OSCE-based summative assessment was carried out in both the groups. Post-test, both the groups subjected to the same post-test as before, and both the groups were subsequently trained in both the methods. Feedback given to both the groups. Similarly, this was the checklist that was developed. As you see at number of places, you see a 0 sign. That means these are the steps that cannot be done on a mannequin. So the OSCE checklist was modified for the simulation-based procedure. And in this case, 50% mark as was accepted as an acceptable score of passing the satisfactory measure of passing the procedural skills and certification. This was the model that was created in the Department of ANT, and we can here see the practice sessions going on taken by the students. And this is the theoretical formative assessment in the department. Standardization of the observation checklist was carried out by faculty members and the express satisfaction of checklist made by the module. Total 3 faculty members evaluated agrees to the list of objectives and checklists made for the module. In the first category, details of the student participated in the study. In the first group, A was male was 11 and female was 14. In the group B, I deliberately made the same proportion of male and the female of the different group. In the present study, we have taken a total of 50 students divided into 2 equal groups. If we see the students of both the groups were made to the pre-test score was more or less similar. I have rounded out the figures to 75. There was a very minor, less than 1% difference between the two groups in the pre-test scores. Average score, this is the score of only the group B students, that is the present study group, and this is the score after PPT presentation 65, video demonstration 70, and practice session was 75. As we see with gradual progression in the module, the students have improved. The number of attempts taken by the student for completing the skill as per Oxy checklist was in group A, it was 4.5, and group B, it was 2.5. So the acquisition of skill so as to be submitted for the summative assessment was faster in group B as compared to group A. The average scores of post-test of both the groups was 80% and 95% in group B. This was a major difference in the two groups. The questions remains the same in the pre and the post-test. Statistical analysis, as we can see, the p-value for group B is statistically significant. Result of test of hypothesis: in the present study, H0 was rejected, which concludes that multiple assessments significantly improve proficiency in anti-nasal packing compared to single assessment module. Diverse assessment strategies implementing multiple assessment methods in skill labs is essential for evaluating trainee progression, proficiency, and effectiveness of training modules. Multifaceted feedback from various institutions instructors offer diverse insights, identifying strengths and weaknesses comprehensively and promoting critical thinking and adaptability. Structural learning via the PPTs help organize information clearly, breaking down complex concepts for better understanding and retention. Visual learning aids. Visual elements like diagrams, charts, and PPT support comprehensive and cater to visual learning, as stated by Sveller. Interactive engagement, embedded quizzes, and prompts in the PPTs promote active learning, enhances the skill acquisition and retention by Clark and Mayer. And video demonstration for modeling video provides a visual and auditory learning experience, allowing learner to observe and replicate expert techniques effectively. This is by Bandura. Flexibility and reduction in anxiety and video demonstration was observed by Sveller and Iron, and comprehensive assessment approach using a combined formative and summative assessment, performance-based and portfolio assessment offers a holistic view of the student progression, encouraging personalized and adaptive learning. Impact of formative assessment. Regular formative assessment provide immediate feedback and allow a real-time instructional adjustment, significantly improving the skill acquisition and training sessions by Black and Williams. Value of summative assessment measures overall competence and are most effective when combined with formative methods. And performance-based assessment for real-world skills. These assessments simulate practical scenarios, enhancing real-world skill application. Challenges and best practices. Implementing multiple assessment faces hurdles such as resources demand, standardization, and study anxiety. And best practices include setting clear objectives, balanced assessment strategies, and continuing feedback. Critical appraisal of the study. The research introduces a multidimensional assessment framework, improved knowledge gain after theoretical presentation, improved knowledge gain after video demonstration, faster acquisition of skill due to better knowledge of the module, and improved procedural skills through multiple assessment methods, which enhances learners' performance accuracy and real-time problem-solving capability. Overall, this study lays a foundation for refining skill training modules and offer a framework for future research in medical education. Limitations of the study. The study on introduction of multiple assessment in anti-nasal packing presents several limitations, like sample size may be limited, potentially affecting generalizability of the finding. The study includes a smaller homogeneous group of participants. The result might not be applicable to all the broader population. The duration of the study might be insufficient to assess long-term retention and competency on anti-nasal packing. Short-term observations might not reflect the skill's durability over a period of time. Without longitudinal data, it is difficult to determine if the skill acquired through the training are maintained over time. Just SWOT analysis of the present study. The strengths are structured in training design, well-organized methodology involving pre-test and post-test formative summative assessments, use of dual feedback mechanism, like feedback was given after the formative assessment evaluation as well as the summative assessment evaluation, and after the formative assessment it was the sandwich method, and after the summative assessment it was the Pendleton's rules. Comparative study design using two groups allows for a direct comparison between single versus multiple assessment. This helps in evaluating the effectiveness of formative assessment. Evidence-based evaluation tools like DOPS and OSCE were used, which are standardized, and there is no doubt about the efficacy of these methods. Knowledge and skill assessment, assessing both cognitive as well as the psychomotor domains, gives holistic picture of learning as per the Miller's pyramid. Weaknesses: smaller size, repeated testing with the same questions like in the pre and the post test, limited faculty involvement for standardization, like only 2 to 3 faculty members were used in the present study, and time and resource intensive. Multiple assessment, feedback and methods, and OSCE evaluation require significant faculty time and institutional resources. The opportunities: improved curriculum design. Insights from the study can inform best practices for integrating formative assessment in medical training. Faculty development: a good faculty involvement can gain from accessing the designs, DOPS, and feedback method. Scalability: if effective, this training module can be scaled up to adapted for over-skill modules across the curriculum and enhanced student engagement. Regular feedback and multiple assessments can keep students more involved and self-aware of the progress. Challenges: maintaining consistency across assessors, like OSCE and OSPE assessments rely heavily on rater reliability. Inter-rater reliability could affect scores. Feedback delivery: delivering effective individualized feedback requires trained faculty and adequate time. Student fatigue or demotivation: repeated testing and assessment may lead to test fatigue or performance anxiety in some students. Logistical constraints: scheduling multiple assessment and practices sessions for two groups may pose logistical difficulties in busy academic settings, which we have already covered. Limitation of the present study: and translatory component actualized multiple step formative assessment MCQ after PP significantly improved study performance and longitudinal retention skill acquisition, at least for the period that the student was in the department. Group B, which received multiple assessment, showed higher post-test scores as compared to the pre-test, higher OSCE scores as compared to the Group A, and statistically significant performance as compared to the Group A. How it should be implemented: to translate the finding into effective practice, the following steps are recommended. Curriculum integration: assessment strategies are to be defined. Faculty training for formative assessment is more important than the summative. Monitoring and generating feedback loops. Policy recommendation: proposal of formal policy to adopt structured formative assessment in all clinical skill labs. Expected benefits from the implementation: enhanced structure, student confidence and competence in practical skills, improved retention and performance in summative exams, reduced limitation needs for OSCE failure rates, and greater student engagement through interactive learning. Protocol has been accepted for publication in the International Conference on Dental Education Curriculum. Paper from the project has been presented will be presented. Paper accepted for publication in JIMA. Paper to be published and module implementation in the Department of PNT, both for postgraduate and undergraduate, working on the module to get patented. These are my bibliography, and thank you so much.
Thank you so much, Dr. Sumit, for your contribution. It was a very insightful presentation. If there are any questions, the chat box is open.